So we're gonna go through the definition of strain and strain rate. We're gonna talk about the different types of strain. We're gonna look at the strain curves, strain rate curve, the displacement curves, and then we'll wrap up with the clinical utility. How do we use this in clinical practice? Um, so again, when we talk about strain uh, and strain rate, it is to remove the question of normalcy, because if you have an abnormal segment, it can give you the appearance that it's normal by the phenomenon we call tethering. That is the passive motion due to active contraction of other parts. So if other parts are normal, the abnormal part may be pulled. So just looking at it, it may look normal. But when you do strain and strain rate assessment, you'll find that it's abnormal. So you can, when we do strain, you can look at the segments, the different segments, and you can determine whether it's normal or abnormal. Because there's some muscle disease that, you know, the muscle may look normal. If you talk about amyloidosis, you know, until you do strain assessment, you may think that it's the segments are normal. All right, so the definition, so this is one thing that you have to get. Okay, it is just, and this is relatively straightforward. So there are different type of strain, but we're using the Lagrangian formula. So strain. So if you say strain is E, strain is equal to change in length with respect to the length. Okay? What we mean by that is take the heart in diastole and we're going to talk about global strain now. Okay? So if you take the heart in diastole, so when the heart contracts, in addition to coming in, uh, you know, from say septum to the lateral wall, the base of the heart is gonna move upwards towards the apex. That is what the heart does. The base of the heart is gonna move upwards towards the apex. And so if you look at the formula, the length in diastole gonna have a certain number. And let me just draw this and show you. So again, so in diastole, okay, so the heart looks like this. Okay, we're just drawing the left ventricle. All right, so just imagine this as a nice, beautiful left ventricle. So, okay, so this is the base and this is the apex. Okay, in diastole, okay, if you measure from the apex to the base, say you get 7 centimeters. 7 centimeters. So this is your diastolic frame. And then your systolic frame when the heart contracts. Remember what we said, the apex is probably going to remain the same, because the apex is going to remain the same, but the base is going to move up, and that's, so you're going to have to use some imagination. Just think of this as a nice, well constructed heart. So the base of the heart is what moves up towards the apex. Okay, so and so you're going to measure now from the apex to the base again, and you probably get 5 centimeters because in systole, in systole, the base of the heart moves up towards the apex, and in diastole it has a certain. So if you plug that into your equation, okay, so L naught is your original length. So L naught is your original length. And then L is the what we call the instantaneous length. So if you plug these numbers in your equation, then strain is equal to 5 minus 7 over 7. Okay, so that's equal to minus 2 over 7. Okay, so a number of things that you need to observe. Strain is a unitless number. As a matter of fact, strain is a fraction, and we when we represent it, we put it in a percentage. We put it in terms of percentage. So this would be uh, minus 2 over 7, which is very close to 0.3 or 30%. Okay, so we usually put strain as a percentage. So when you look in reporting, it's going to be in a percentage. Okay, and this is what we call longitudinal strain, because in systole, if you look at the heart in a longitudinal frame, um, the base is going to move up towards the apex in systole. All right, so the definition of strain is your instantaneous length minus your baseline length over your baseline length. Okay, again, it's dimensionless, and we express it as a percentage. Okay, for longitudinal strain, it's a negative number. However, we have radial and circumferential strain, where in when if you look at the heart, if you look at the muscle of the heart in systole, it thickens. So if you talk about a radial strain, your baseline length is going to be less than your instantaneous length. So it's going to be a positive number. But for clinical practice, we report mainly on longitudinal strain. So what I just did here is look at global strain, but you remember that you divide your say you divide your LV into different uh, segments. So you can look at the strain for each segment. Okay. All right. So you if you put numbers in, you can work out the strain. Okay. Basically, what we're saying is that in systole, the base is going to move up towards the apex. It's going to shorten in systole. Okay. So that is strain, and strain rate is strain per unit per time or per unit time. So it is the rate at which strain is occurring. Okay, so it is a strain per unit time. So strain rate is just you you get your strain and you divide it by the time it takes for the muscle to shortens or lengthens. Okay, so again, strain rate is uh, the change in strain with respect to the change in time. Okay, so if you were to plug these stuff in your strain rate, so again, change in strain, strain has no dimensions, it's dimensionless, and it is divided by change in time, which is second. So the unit for strain rate is second to the minus one. Okay, it is second to the minus one. Okay, so all right. So I think this is relatively straightforward. All right. So these are what we call deformation parameters. That is, the heart is going to change shape. So again, as we say, in systole, the base moves up towards the apex. So the heart is deformed. Okay. So the broad definition for deformation is when an object is not moving overall, but different parts are moving, and the heart satisfy that criteria. Um, so strain and strain rate are what we call deformation measures, okay? Because the heart is it is shortening, it is lengthening, it is thickening. Uh, the heart is not really moving out of the chest, but the different parts of the heart are different segments are moving. Okay, and again, the just to drive home the message, the the overall volume of the heart is relatively constant, even though in systole it shortens and diastole it lengthens. But when the heart shortens in systole, it thickens. So the overall volume is essentially the same. Because just imagine, or just picture it, when the heart contracts in systole, the base moves up towards the apex. So the heart shortens, but the muscle also thickens. So if you were to do a volumetric analysis, the volume of the heart remains the same, even though it's doing all of this. Okay? So we usually say that the myocardium is incompressible because if it shortens, it's gonna lengthen somewhere else so as to keep the volume constant. Okay? All right. The different types of strain, and we have gone over this. You have longitudinal strain, radial strain, that's this transmural radial strain, and circumferential strain. In clinical practice, we use only longitudinal strain, but you need to know that the other strains exist. Okay? Um, so when we talk about longitudinal strain, again, I drew it, but this is what the heart does. So this is your apical four-chamber view, your apex and the base of the heart. Okay, so this would be your baseline length. Okay, and then in systole, the base of the heart moves upwards. Okay, so it moves up, and we call this, you can call it delta L if you want. So it moves up this amount. Okay, so it shortens. So your strain would be LS minus LD divided by LD. So this is your strain. Okay, and then the strain rate is the rate at which strain is occurring. So you divide it by the change in time. Okay, so this is your longitudinal strain, and this is what we use mainly in clinical practice. Okay, in systole, the base of the heart moves up towards the apex. It shortens. Okay, so this is global strain. But as I pointed out, we can do strain assessment for each segment of the myocardium, each segment. Because remember, if you have a muscle pathology, it may involve only one segment. So you can do strain and strain rate assessment for different segments of the myocardium. And see, okay? So those of you who are following closely, you can see that the difference in your diastolic and your systolic longitudinal measurement is what we call the myocardial annular excursion. Basically, what we're saying is how much it moves up. Just like you'd have TAPSE, it's the same thing. So, over on your left side, we actually call this MAPSE. Okay, mitral annular plane systolic excursion, same thing. So, in systole, the base of the heart moves up. Okay, the base of the heart moves up, and how much it moves up, what you have to do, you have to subtract this length from this length. Okay, so in diastole it's going to have a certain length, in systole it has a certain length, and if you get the difference between the two, then you'll get the mitral annular excursion, how much the heart moves up, how much the base moves up towards the apex. So this is what we call radial strain. So if you look at the heart, if you look at the short axis, and this is at the mid cavitary level because you have the papillary muscles. In systole, the heart muscle thickens. In systole, the heart muscle thickens. So you're gonna in diastole, you're gonna have a certain length or a certain thickness, but in systole, the thickness is going to increase. So when you plug that into your strain formula, you're going to get a positive number. So that's why we say radial strain is a positive number. Again, in clinical practice, when you send someone for a strain assessment, when you send someone to the echo lab for a strain assessment, we don't do radial strain, mainly longitudinal strain. Okay? And then so that's your radial strain. And then when we talk about circumferential strain, what we're referring to is, okay, so in diastole, let's take any area. So you can take, this circular portion of the muscle. So it's a short axis. We're calling the heart in short axis. So in diastole, it's going to have a certain radius then. Okay. This portion of the muscle, if you look at all the area, all the muscle in this area, it's going to have a certain radius or diameter, let's say radius from the center. When the heart contracts, then everything is going to move towards this point here. So your radius is going to decrease. Okay, the radius is, so that's what we call circumferential shortening. So in if you just look at this area right here in diastole, in systole, it's gonna get less. Okay, so you can see, so diastole is the red broken arrow, and then the blue broken is in systole. So the heart squeeze in systole. So that is what we call circumferential strain. We don't use that in clinical practice. There's still a lot of experimental work going on with circumferential strain, but you don't have to really know about that right now. We talk about the mitral annular excursion and it is the same. It's relatively the same thing as your MAPC, and M mode is a very good method to measure that. All right. So we for deformation parameters, we can use tissue Doppler imaging. Again, as we have pointed out before, speckle tracking echo is much more accurate. So almost no vendors at the current time is using tissue Doppler to look at deformation measurements. Okay, but anyway, so again, if you look up top here, you have your apical four-chamber view, and your cursor is at the medial mitral annulus, and you press it. Of course, you're gonna get your S prime because in systole, okay, so S prime. So these are our velocity measurements. So in systole, the base of the heart moves up. Okay, so it moves towards the transducer, so it's above the baseline, and it's going to have a certain velocity associated with it. And then in diastole, you have two diastolic components. You have your early diastolic component and your late diastolic component. So we call this S prime, the systolic component, and then the early diastolic component, we call that E prime. The late diastolic component, we call A prime. Okay, and then when you put it in your lateral annulus, you get the same thing. You get your S prime, and you get your E prime, and your A prime. Again, at your lateral annulus, it's normal for the E prime to be much greater than your medial E prime. So the lateral E prime is usually much greater than your medial E prime. But yeah, speckle tracking echo is the way to go. All right. So, all right. So the you can again, strain rate is the rate at which you get strain. So it is strain divided by time. Okay. All right. So this is your strain curve. So we've been showing you this forever. And this right down here is what we call your peak strain. The peak strain. So this is longitudinal strain, the curve for longitudinal strain. Okay, and then this lowermost portion is what we call the peak strain, and the peak strain should be greater than 18. And the reason why it has a negative number associated with it is because you're getting shortening. Okay, so if you're looking at from a purely mathematical standpoint, it's just a percentage shortening of the muscle. The muscle is supposed to shorten, by a certain percentage. Okay, and because it's shortening, that is why it's negative. Okay, so and because it's the number is negative, that is why below the baseline. But anyway, the peak strain should be greater than minus 18. Okay, that is, it should be minus 19, minus 20, minus 21, minus 22, 23, 24, 25. Okay, but this is what the strain curve looks like. Okay. Again, this is the definition for strain, and then if you look at longitudinal strain, that is why it's a negative number, because this is your diastolic length, which is greater than your systolic length. So when you plug the numbers in the equation, you're going to get a negative number. So longitudinal strain is a negative number. And this is your strain rate curve. So this is your strain rate curve. And, you know, you will say, well, how can I because one of the questions that you're going to be asked is to identify the curve. So how can I identify the strain rate curve and separate from the other curves? Because you're going to have a multiple. You're going to have velocity curves, you're going to have displacement curve, and you're going to have strain rate curve. How can you distinguish these curves? So your strain rate curve is a temporal derivation of your strain. Because remember, we said that strain rate is strain per unit time. So your temporal derivation of strain is your strain rate. So your ECG is right down here. So in systole, okay, so in systole you have a downward displacement, and then in diastole you have a upward displacement. So if you look closely, your strain rate curves look like an inverted velocity curve. So remember, your velocity curve, you're going to have an S prime, but this S prime is going to be above. So this would be like your S prime, and then this would be your E and E prime. But they are inverted. So okay, so it's your strain rate curve, which is a temporal derivation of strain. All right, so displacement curve, which when you talk about displacement, you talk about the movement, the distance traveled. So your displacement curve, it will look like this. Okay, so this is your displacement curve, and then your velocity curve. You recognize this is your S, so your so-called S prime, and then your E prime and your A prime. So you can figure out this your velocity curve, your tissue velocity curve, because you have your S, your so-called S prime, your E prime and A prime, and your displacement curve. I think so. Your displacement curve looks similar to your strain curve, but it's upwards. Okay, so your displacement curve looks similar to your strain curve, but it's upwards. And then the only one so your strain rate curve, looks a little bit funny, but it's probably, well, not probably, it looks like your velocity curve inverted. Okay, we'd call this your S prime, and then you have your E prime and A prime. And then your strain curve looks like your displacement curve, but it's inverted. So you'll get multiple questions on strain. So this is the one that you absolutely have to know. All right, well, you should know all of them. You should know all of them, all of your curves. There's another, we talk about parametric imaging, and parametric imaging is based on color display. Of course, velocity towards a probe is red, velocity away from the probe is blue, when you talk about uh, strain rate is yellow to orange for shortening. So if the muscle is shortening, you're going to see yellow to orange coloration. And then strain is cyan to blue for lengthening. Okay, so cyan or blue for lengthening, and then strain rate is green for if there's no deformation, strain is green. So it's you have to go over these, and you'll see these in your echo from time to time. Okay, sorry. So you will see these in your echo, in the echo lab from time to time, and you probably should, you know, so the color means something. Um, it's not to pretty up the image. Okay, so parametric imaging. No, so this is what we did the last time. We look at the bullseyes or the polar plot, and again, when you see a polar plot like this this is your 17 segment or 16 segment uh, uh, assessment of the heart. So you have to know your segment. Remember, the apical cap is right inside here. Your apex is outside. You have the anterior wall, inferior wall, the lateral wall, and the septum. And then just outside of that, you have your basal level, short axis at the basal level. You have 6 segments. You have your anterior wall, inferior wall. This is your inferior lateral, your anterior lateral, and then when you have the septum, you have an anterior septum and your inferior septum. Okay, and then you have the basal segment. Outside of that, 6 segments as well: anterior wall, inferior wall. This is the lateral, so your inferior lateral, anterior lateral, septum is over here, inferior septum, anterior septum, and then the number is for the peak systolic strain. Okay, the number is for peak systolic strain. So remember what we said, anything greater than minus 18 is normal. So your minus 10 is definitely abnormal. So basal anterior wall is abnormal. And not only we give you the number, but we give you varying shades of red. Bright red is normal, and then lighter shades of red is abnormal. So in addition to the number, you can see that you know you have a lighter shade of red there. So minus 10 is definitely much less than minus 18 in terms of percentage change. So so if you can accurately identify this segment, this is your basal anterior wall. And then 14 is a little bit abnormal, so it's a little lighter shade of red. And so 17 is probably borderline, 18 is not bad, 22 is normal, 20 is normal, 20. So you can accurately identify the segments by looking at the peak systolic strain, and it's also color coded for you. Okay, lighter shades of red means that the muscle is abnormal. Okay, so what are some of the clinical utility for strain and strain rate? Patients with coronary artery disease, again, if you have heart muscle that is uh, devoid or don't have sufficient blood supply or is infarcted, uh, eyeballing it, it may look normal because it's been pulled by the normal segment. But when you do strain assessment, you will see that it's abnormal. Other, yeah, for cardiac resynchronization, myocardial disease such as amyloidosis, valvular disease, and diastolic dysfunction. Okay, so those are some of the more and also for chemotherapy. Chemotherapy is also one of the emerging areas that we use strain assessment. Someone who have breast cancer, and before they start chemotherapy, you want to get accurate evaluation of cardiac function, and then during therapy, uh, you also wanna evaluate the function, because some of these chemotherapeutic agents can damage the heart muscle, weaken the heart muscles, and give the patient a cardiomyopathy. So you want to get a very accurate assessment of cardiac function. Uh, and one of the best way to do that is by strain analysis, strain assessment. All right, so I'm not sure what we're going to do on Thursday, because people are preparing for their exams. Um, so the question is, should I do chemotherapeutic patients on taking cancer drugs? Yeah, this is probably a very one of the most accurate method to assess cardiac function. So if you have the capability of doing strain assessment, patients who come to the echo lab um, for cardiac function assessment, you should do strain assessment on them, or strain evaluation on those patients. Um, yeah. So on Thursday, I'm not sure what we'll probably find something to do, but uh, the first years are preparing for their exams. So the exams started on Saturday, and it goes to this weekend. We make a special exception for some of the doctors who are in the program, because I'm not sure what's going on, but they're going to do the exam on next week, Monday. So anybody else who wants to do the exam number 3, uh, you know, they can just let us know. All right, so strain evaluation is being done more and more, and you're going to see a lot of reporting um, on strain. So you need to know how to read it, and you need to know when you get a report, what the report means, how to interpret the report. Okay, and then if you're doing strain in your lab, then you need to know what you're doing. Okay, all right. So we're going to end the session now, and